Hello and welcome to my opthal teacher. So continuing with our lamellar keratoplasty, we are going to talk about posterior lamellar keratoplasties or endothelial keratoplasties in the subsequent two lectures. So this one's about DSEK. Okay, DSEK is a type of posterior lamellar keratoplasty. So three types. Descemet stripping endothelial keratoplasty where the donor thickness is 180 microns. Now, please remember that diagram of individual corneal layer thickness that I showed you. Please go back to the previous lecture and revise it so that things are easier to understand. Descemet stripping automated endothelial keratoplasty, where the donor thickness is less than 100 microns because an automated microkeratome is used here. So DSEK and DSEK, the 1 and 2 are fundamentally the same thing, except microkeratome being used in DSEK to perform the donor harvesting. Okay. And the third, DMEK or descemet membrane automated endothelial keratoplasty. Um, this is an advancement over DSEK, and the most recent one, which is an advancement over DMEK, is PDEK. So in this lecture, we're going to talk about DSEK. In the next lecture, we're going to talk about DMEK. So DSEK is still the most commonly performed endothelial keratoplasty or posterior lamellar keratoplasty procedure, right? So you see, this is just a schematic of descemet stripping endothelial keratoplasty. Descemet stripping, why? Because we're going to strip the descemet membrane of the recipient, the diseased descemet membrane and endothelium of the recipient, okay, using a specialized instrument, and we're gonna implant or rather transplant a healthy donor descemet plus endothelium over there, right? So same thing in both the diagrams, but here the lenticule, the DM plus endothelial lenticule is prepared manually, whereas here it is prepared with the help of microkeratome. It is thinner and smoother. So DSEK is the surgery that is being performed. Always better than the manual one. And in DMEK, descemet membrane endothelial, here also the descemet membrane scoring has to be done, right? In all the three procedures, you have to strip the descemet membrane of the recipient. But in this case, you are just transplanting a healthy descemet membrane plus endothelium. Whereas in this DSEK, in both the cases, some amount of stroma invariably is also transplanted. That is why the lenticule is thicker here, right? Obviously, if it is 100 microns, it must be having a part of the posterior stroma as well, right? DMEC lenticules are typically 20 microns, about 20 microns in thickness, and they include only the DM and the endothelium. So let us proceed with DSEK. Indications: any type of endothelial dysfunction, endothelial dystrophies such as Fuchs, advanced Fuchs, bullous keratopathy such as pseudophakic, aphakic bullous keratopathy, ICE syndrome, irinocorneal endothelial syndrome, endothelial decompensation from surgery or trauma, late endothelial failure of prior penetrating keratoplasty. Absolute contraindication is when there is significant subepithelial or stromal scarring. There is no point in transplanting the endothelium in such cases because the visual outcome will not be satisfactory. Now, donor age. In PK, according to the IMAC Association, who can be the donor for PK? Anybody between the age of 2 to 75 years. Whereas for DSEK and DMEC, that is not true. In DSEK, the desirable age is 25 years or more, because a cornea that is younger than 25 years is going to have less corneoscleral rigidity, and this is going to be a problem if a microkeratome dissection is being done. It gives an irregular microkeratome dissection, okay, because of the lesser corneoscleral rigidity in young patients. So preferably the donor should be older than 25 years of age. This is for DSEK. For DMEC, the lenticule, the donor lenticule is still thinner, okay? It is made up of only the descemet membrane and the endothelium. So the age is still more, above 50 years. But of course, there has to be an upper limit because at very extreme advanced age, the endothelial cell count would be less, and again, that would defeat the purpose. So preferably above 50, but less than 70 years of age. Why above 50, below 50? Again, because of younger age, the descemet membrane the lenticule has tighter scrolls. Now you will see as in the subsequent lectures that in DMEC the donor lenticule is made up of only the descemet membrane and the endothelium. It is about 20 microns thick, right? And it has a very high tendency to get scrolled or fold on itself, right? It coils up, right? Why? Because that is a property of the descemet membrane. It has a tendency to coil up, right? We have seen this in descemet detachments also. The descemet membrane, if detached, it has a tendency to form scrolls. And how does it scroll? It scrolls on itself such that the endothelial side is always facing outwards. Please remember this when we are talking of posterior endothelial or posterior lamellar keratoplasties. So this scrolling is less when the patient is a little older, right? So that's the donor age. Scleral rim size 16 to 17 mm to mount the donor tissue on the artificial chamber. Endothelial cell count more than 2000 is desirable. Donor lenticule should be 3 mm smaller than the recipient. Obviously, if the donor lenticule, which is being transplanted on the posterior surface of the cornea, is larger in diameter than the recipient cornea, it's going to block the angle and cause angle closure. Shape: a meniscus shaped lenticule is preferred because the hyperopic shift is predictable in such cases. We're talking about DSAEK in this particular point. Hyperopic shift happens only with DSAEK, not with DMEC. Storage. Now, the donor lenticule is stored in BSS or specialized storage media. And remember, since the posterior surface of the cornea is of larger diameter than the anterior surface, endothelial keratoplasty buttons are typically larger diameter than PK buttons. Okay, that makes sense. So donor preparation for DSEK, these are the things required. Now what you have to note is that the specialized instrument, you need an artificial anterior chamber. Okay, this is required to prepare the donor tissue. So that is why this is a specialized surgery. Okay, we do not need an artificial anterior chamber for a DALC, okay, or a PK, but it is required in cases of DSEK and DMEC both. And what is this? This is a trifine, and this is a donor corneoscleral rim, right? So this is a trifine punch, also known as a Teflon block. So this white part is actually Teflon, and this is the trifine, which is a circular blade. And this is your artificial anterior chamber, right? And you will understand the rest of the instruments as I show you them. So about donor preparation, okay? How to prepare the donor button or the donor lenticule for DSEK. So it is placed on the Teflon block, endothelial side up, right? I'm sorry, not the Teflon block, that's the artificial chamber. So what it does is once you lock it, it creates an artificial AC, anterior chamber. The outline is marked, a groove is made with the help of a crescent, okay? And you're going to use the crescent blade to make a tunnel into the posterior stroma. Then you're going to use a special blunt dissector to, make that plane in the posterior stroma. Okay, so the dissection has been performed. Now the donor button is centered on the Teflon block. This white thing is a Teflon block on which a trifine punch is placed carefully and punched out. So that's the donor button that is ready for you. See, that's the donor button, right? Now this donor button, you have already made a plane separating the posterior stroma from the underlying DM. So when you're going to transplant it into the recipient eye, you're just going to peel off that stroma from the descemet membrane and easily transplant it. Now, surgical technique for donor preparation. So what you just saw was a manual dissection, and that is known as DSEK. The same procedure, if performed with the help of a microkeratome, is known as a DSEK with an A, right? So basically, the microkeratome does the job of posterior stromal dissection. So naturally, this is at a predefined depth. It's a mechanical device, and it is much more accurate. And most recently, the femtolaser dissection is being used to make that stromal plane, right? Now, just listen to the surgical steps and subsequently I'll show a video also. So, surgical steps performed for the preparation of the recipient eye. What is done? Now, a 3 to 4 mm sclerocorneal tunnel is made. All of you are familiar with the SICS tunnel, right? So this is just a small, little, tiny SICS tunnel, okay? Then you make a side port and you have to put an AC maintainer. Then you do a scoring of the descemet membrane, right? The endothelium is stained with trypan blue. The size is marked on the corneal surface, and with the help of a reverse Sinski, the descemet membrane is scored or scratched all around. Okay. Then the AC maintainer is closed. Donor lenticule is inserted into the anterior chamber, for which there are several techniques. BSS is used to oppose the donor lenticule to the recipient bed. The tunnel is sutured. Once the lenticule is correctly positioned, a 100% air bubble is injected into the anterior chamber. We wait for some time. We allow the donor button to, adhere to the recipient stromal bed. And then we burp it, or we reduce the size of the air bubble such that pupillary block does not happen. There are other steps we take to prevent pupillary block. That includes an inferior PI, burping I told you, and of course cycloplegics. So let us just look at the surgery. Remember the steps that I told you. So here the epithelium is being removed. This is the recipient. Epithelium is being removed for better visualization. The side port is made. That's your tiny scleral tunnel. These days, 3 mm scleral tunnels are even being made. Trypan blue to stain the descemet membrane. And now descemetorhexis, that is the 360-degree scoring of the recipient descemet membrane is done. Right? That's the diseased part along with the endothelium with it. So 360-degree scoring done with the reverse Sinski. You see how the stained descemet membrane is coming off. Now that stained DM is pulled out carefully with the help of a blunt forceps, right? It is laid on the cornea to ensure the whole circular DM has been removed, right? And all the viscoelastic has been washed from the anterior chamber. So that's the graft. See, we are peeling off the descemet and the endothelium with some amount of stroma. And with the help of a specialized instrument, the donor lenticule is injected into the AC. There are several specialized instruments available for the same. The tunnel is sutured. The graft is positioned. Air bubble is injected to oppose it better. So that's 100% air bubble, right? And in the end, some burping was done to remove the air bubble from 100% to 80% so that pupillary block does not happen. And cover with a bandage contact lens, because remember, we removed the epithelium in the beginning. What are the complications? Intraoperative complications. One can perforate the donor tissue. Graft inversion, expulsion, loss, or damage can occur. Obviously, these graft related problems will be there. Inversion is when you put it with the endothelial side up in contact with the recipient stroke. So that's wrong orientation. Difficulty in bubble management, bubble related problems like pupillary block glaucoma. Anterior chamber hemorrhage or presence of fibrin can happen. Interface, vitreous, or there is an interface, so interface related problems are bound to happen. So that's intraoperative. Postoperative complications include graft dislocation or detachment. All these could be the causes of the same. Primary graft failure or secondary graft failure, I've talked about this. Air related complications, yes, can happen postoperatively also. Interface problems, yes. Glaucoma because of steroid response, angle closure, or chronic inflammation can happen, right? Benefits of DSAEK when compared to PK: faster recovery, preservation of anterior corneal curvature, so less postoperative astigmatism, tectonic strength of the globe far superior, even better than DALK, less chance of suture related problems because there is no suturing except the one that is needed at the tunnel, right? So thank you. That was all about DSAEK, and please continue watching my subsequent lecture on DMEC. That is the last one about lamellar keratoplasties.